Thank you so much. And my name is Padmini, Minnie, not related to Minnie Mouse. And it gives me great pleasure, and it's an honor to present this diverse panel. And I think Dr. Navarro, with his great sense of humor, but also what he said, set the stage for us. So it's really a hard act to follow, but I'll try my best. The name of our panel, as you can see, is from the MDGs to the SDGs. We didn't misspell anything here, ladies and gentlemen. It's from the Millennium Development Goals to the Sustainable Development Goals, the future of global health. And this panel, I have Dr. Ivey Boufford here, and I have Ms. Sherine Guirguis, and I have Dr. Corinne Whittaker. And the way we're going to have this, I'm going to give you lightning introductions to about each of our speakers, and then we will go ahead and give them their 5 minutes. And after that, I have some questions I'm going to be asking them, and then hold your breath. I'm not shutting you out. I will turn it over to you to learn and ask questions from our panelists. So, to get started, Dr. Boufford is the president of the New York Academy of Medicine, and Dr. Boufford is somebody who's just not been in practice, she's been in policy, and she has been doing a lot of work both globally and nationally, and I'm proud to say she was my teacher, and she really rocks. So we need to have some humor here because we can't have people sleeping. I know you had lunch. It's a cold day, but please listen because this is really crucial. And Dr. Boufford will be talking to us about an urban health agenda. And it's really important because this panel will discuss not only infectious diseases, but also non-communicable diseases or chronic diseases. So without much ado, it's my pleasure to have Dr. Boufford take the mic. Thank you so much.
Thank you very much, Minnie. Thanks. Is there a cue do I cue you for the slides? Very good. Thank you. I'm very pleased to be here, and happy to join my distinguished colleagues at this UN Association Members Day, and also to really congratulate all of you for your interest in and support of the UN. I think, as David said, and most of us feel, it is inadequately resourced for the task, and especially in the health area, and it is really, in many ways, the only solution to many of the kind of complex problems is getting a global consensus and mobilizing and aligning global action. My organization, the New York Academy of Medicine, is especially committed to urban health. We've been advancing the health of people in cities since 1847. And it's the unifying theme of our work. We focus especially on healthy aging, prevention, and eliminating health disparities. We are also a WHO collaborating center on aging, globalization, and urbanization, and the secretariat for an organization called the International Society for Urban Health. As you know, UN member states are in the final year of an intergovernmental process to develop a set of SDGs, which will drive the implementation of sustainable economic, social, and environmental development worldwide over the next 15 years. If I have the first slide. There are a number of new health challenges to stakeholders engaged, next one, in this process that were not major factors in the MDG process, and you'll hear the report of that in September. I've picked four that I think are very critical. One is the epidemiological transition, as Minnie said, from infectious disease to non-communicable diseases, chronic diseases. The second is urbanization. The third, the demographic transition, the aging of the population. And finally, climate change. I'm going to focus my brief time with you today on urban health and on the issue of aging. I think David didn't mention this, but one of the real challenges of managing the Ebola outbreak was the fact that there were cities involved. This is very different from the historical outbreaks, which has been largely in rural areas. So we can see the complexity added to that problem. So first, on cities, if I have the first slide, several years ago we reached a remarkable threshold. More than half of the world's population now live in urban areas. By 2050, it's estimated that 70% of the world's population will be urban dwellers next. It's already presenting challenges for all countries. The pace and scale are greatest in low and middle income countries. The red line, you can see the slope of that line in terms of the growth of urbanization and urban populations in less developed countries. And given the scale of these projections, I think it is a welcome fact that the SDGs are acknowledging the importance of urban populations in achieving overall global health and development. Several unique characteristics of cities are often cited as critical to planning and leadership for health at the city or local level. Density of population, of buildings, diversity of race, ethnicity, age, cultures, complexity. I couldn't resist, next slide. I couldn't resist showing you the org chart of the New York City government, just so you have a sense of the complexity of managing change. And the issue of health disparities and inequities, which are a particular issue in certain neighborhoods of cities. And if you take averages of urban populations, you miss them. And this is one of the real challenges of working in cities. So in a world that's increasingly interconnected, they're becoming increasingly important. So next slide. I want to make a really important point here. Cities are neither good or bad. These are the characteristics of the cities I mentioned. You can see positives, negatives, and a way forward. Cities are drivers of national economies and offer access to a very wide array of goods and services, and many people migrate to cities for economic opportunity and a better life. The physical, social, and built environments in cities with dense populations allow delivery of services in a more efficient way than may happen in some rural areas. Effective management of urban settings can improve access to these services. But cities can also be sites of extreme poverty and environmental degradation, as well as infrastructure problems. And urban dwellers also sometimes face unique challenges of physical and mental health, stress-related violence, poverty, and unemployment. Slum dwellers and informal settlements are a major concern in the development of cities, the uncontrolled development of cities, and many cities without legal status and services are very hard to support. And finally, I want to say that an extensive literature shows that good governance is an important determinant of urban health. And so political support and the ability for political leadership to see the opportunities in governing for health is a very important statement. So the next slide shows the relevance to the SDGs. The official draft that we're currently working with includes health targets number 3, which is quite detailed, ensuring healthy lives and promoting well-being for at all ages. It is critical to address the specific issues of urban populations and taking up those challenges. And also, for the first time ever, Goal 11 is an urban goal, aims to make cities and human settlements safe, resilient, and sustainable. The word health does not appear in the urban goal. The word urban does not appear in the health goal. And this is an example of, I think, some of the stovepiping that happens in international development. So one of the challenges is really understanding how, without changing the goal, one can be aware that all of the variables that will address urban well-being are, in fact, promoting health and human health at the same time. So let me shift gears in my, hopefully, I think probably over a bit, but 2 minutes. I want to talk about aging. And it really remains to be seen how the SDGs will recognize and address the aging of the global population. This is a worldwide phenomenon. It's growing in low and middle income countries as well as high income countries. Between 2000 and 2050, the population, the world's population over 60 will double from 11% to 22%, and in Africa will increase 4 times the current level. So this diagram represents the WHO paradigm to promote healthy aging. It's a very important frame shift from seeing, and this is particularly hard for Americans, seeing healthy aging as a public health success, not a crisis that's going to swamp the social security system or the healthcare system. And it's very important to take this life course approach. The green line here that's moving is the so-called line of disability, and beginning in early life, you have a chance to influence an individual's health and well-being through a variety of activities, one of which is healthcare, but many of them have to do with the built and natural and social environment and economic and educational opportunities. So the idea is to create environments that keep that disability threshold down and raise the range of function of individuals so that they can, in fact, stay active and independent as well as engage in their communities. Next. The World Health Organization model identifies 8 domains of age friendliness that, if attended to, can reverse or slow this disability trajectory. And the message is that the age-friendly movement is not about helping people only age in place. It's about creating environments that are interesting, supportive, rich, inclusive, and accessible to individuals of all ages, socioeconomic status, race, and ability. And in New York City, we at the New York Academy of Medicine have been involved for over 7 years, creating the age-friendly New York City model that involves very wide-ranging, starts with the words of older persons telling us what makes it harder or easier for them to live in their communities, and grows on from there to bring in expertise next. And as a result of these efforts, you should ask yourself, why are people in New York City interested in this? A 47% increase in people over 60. By 2030, there will be more people over 60 in New York City than school children. This gets the attention of local elected officials. Next. And so as a result of this project so far, we have 22 city agencies collaborating on 59 initiatives for the city government, and a public-private partnership mobilizing the private sector to collaborate. The WHO Global Network now includes 210 age-friendly cities covering 88 million people. So this is a worldwide movement, and it has actually picked up less in the US than in other countries. Ireland, I believe, is an age-friendly country, so there are challenges there. But last slide, the last thing I wanted to say is our challenge, and I think opportunity for the SDG process, is to increase the focus on cities as an important level of governance to act for health, and a sensitivity to the needs of its older adults and all older adults, so we can assure that cities that we have are truly healthy for all ages. Thank you.
Thank you so much. Now you know why I said she rocks, because I think what you brought to the audience here is not only New York City, which we are so globalized, but looked at issues we are really concerned about, and it was kind of a smooth transition after what Dr. Nabarro was speaking to say that there are other issues too. So now to shift gears, and it's really great to have Ms. Sherine Guirguis here, who is from the UNICEF and Senior Communications Manager. And Sherine just got off from a plane coming from Pakistan, and it's great that she's here with us. We really appreciate that. And Sherine is going to be talking about ending polio and ending epidemics. So you see the transition of how, so we're trying to weave this, so it's like really three-dimensional, and that's what global health is. You just needn't be a health person. You can be anybody who's committed to make sure global health works, and we make it work. So Sherine, the mic's yours. Thank you so much.
Thank you so much. Thank you, Minnie. And it's really nice to see such a diverse and full room of people interested in global health. I was very similar to you about 15 years ago, sitting in forums like this. So it's very nice to see the new generation and even my own generation sitting in a room like this. So I'm going to talk about a very old disease, polio. And looking across this room, I'm wondering how many of you remember what polio was like in the United States about 60 years ago. Okay, a fair number of you. So those of you who raised your hand will remember very well that polio in the 1940s and 50s in the US was one of the most dangerous and feared diseases. As the weather turned warmer every year, each summer, during the high season of polio transmission, you could feel the panic intensify across communities. Public swimming pools were shut down. Movie theaters urged people not to sit too close to one another. Insurance companies even started selling polio insurance for newborns. In 1952, it was the peak of polio transmission in the US. 58,000 polio cases occurred in a single year, which was the highest burden of disease for polio in our history. Special hospital units with iron lung machines were set up to keep polio victims alive. And everybody was affected. It was really a disease that affected the rich and the poor alike. But in 1955, Jonas Salk developed his polio vaccine, and mass vaccinations began across the country. So 12 years later, by 1964, cases went down from 58,000 to only 121 children paralyzed in the country. But it took 15 years after that, in 1979, until the last polio case was identified in the United States. So the effort to end polio in the United States took 27 years. And the last leg of that battle, to get from 121 to 0, took 15. In 1988, after the success of the US and the Americas, the World Health Organization partnered with UNICEF, the Center for Disease Control, Rotary International, to set a goal to eradicate polio from the world. And after smallpox eradication, finishing polio would mean it would be only the second time in history that a disease was wiped from the earth. And this year, ironically, the global eradication effort to end polio in every country is also on its 27th year of work. So many of you are looking surprised. Many people think 27 years is far too long to spend on any disease, and certainly a disease that only affects 100 children now every year. Critics of the eradication effort say that billions of dollars have been poured into this disease when it could have been used for other life-threatening diseases, and it now only affects just 100 children per year. Many people think it is a never-ending epidemic. So what have we learned in 27 years about ending polio and ending epidemics, and what does it mean for the future of health policy? Between 1988 and 2011, the number of polio cases went from 350,000 children per year to 650, a decline in over 99%. So the first lesson is that vaccines work. When children have access to vaccination, preventable diseases decline. The oral polio vaccine costs just 15 cents per drop, and it takes 3 drops, 3 rounds to prevent polio paralysis in most countries of the world per child. So for under 50 cents a child, you can prevent lifelong paralysis. So after a decade of intensive vaccination campaigns in India, many people thought India would never eradicate polio. But in 2013, India and the 200 million children under 5 in that country were declared polio-free, which was a huge, huge victory for the polio eradication initiative. Indeed, it was a huge achievement. So after India was eradicated, the number of cases went down substantially in the world, and last year the number of cases in the whole world was 366. Polio now remains endemic in just 3 countries of the world: Pakistan, which I've just returned from, Afghanistan, and Nigeria. So lesson number 2, as we learned from the US and as we are learning now in the Ebola crisis, going from the last few cases of polio and any disease down to 0 is the hardest part of the job. I hope it's not going to take us another 15 years, but we do know that it is going to be very different to get to 0 than it did to get as far as we have today. So why are these 3 countries the last in the world to eradicate polio? Eradicating a disease and ending an epidemic means cutting a virus off at its source. It means getting to every last person who could be spreading a disease, rich and poor, and the poorest of the poor. In each of these countries, the social determinants of polio echo the health disparities that pervade more broadly. These disparities are rooted in and compounded by poor health infrastructure, conflict, political fragmentation, and extremism. In Nigeria, only 25% of children under 2 are fully immunized. Conflict and communal violence have forced hundreds of thousands of people to flee their homes. In the Northeast, many health centers have been destroyed and health workers have been attacked. This conflict has affected polio vaccination and many other diseases, as several 100,000 children cannot be reached because of security. In Pakistan, 30% of children under 5 are chronically malnourished and lack access to basic sanitation. In the past 2 years, over 30 health workers have been targeted and killed while delivering polio vaccinations to children. It is the only health program in the world that has seen a deliberate targeting of its health workers. Due to this violence and bans across the country, over 200,000 children have never been vaccinated with polio over the last 2 years or any other disease. So the third lesson is polio and other epidemics breed most persistently where the health systems that are meant to protect every child have failed those who need them most. We've learned the same lesson in West Africa, as Dr. Navarro has just told us, where Ebola has ravaged entire communities, exploiting the fragmented trust and broken health infrastructure that has been slowly crippling the health of the poorest and most marginalized for decades. So our success with polio eradication has taught us that it is possible to reach every child with basic health services. 27 years of fighting polio and now Ebola have helped shine a light on the pockets of vulnerability that threaten our collective progress in overall health and development. The epidemics have also shown us how truly interconnected we are. The United States today, along with 122 other countries, are polio-free and they are Ebola-free, but nobody is risk-free. Until universal health coverage is equitable and reaches the poorest of the poor, we risk undoing the collective hard-won gains of the last few decades. In the post-2015 era, we must demonstrate what we have learned from these epidemics. We must remember that we have the means to reach every child with health services. We must apply these learnings and ensure that epidemics no longer take us decades to squelch. Sustainable development post-2015 must be equitable development. We can end polio in our lifetime, and we can end epidemics. Thank you.
Thank you, Sherine. I think everybody agrees with me that we are so glad you're working at UNICEF to get this message across. And one thing which struck me, not that everything else didn't strike me, but when you talked about the cost-benefit analysis of investing so little to get gains, immediate gains, and over a long period of time. And moving on, our last speaker, but not the least in any way, is Dr. Corinne Whittaker. And Corinne has been all over. By that, I mean she's worked in the UN, she's worked in the private sector and not-for-profit. So she really brings a very interesting perspective. And I'm just going to read her title. I need to read it because it's so long. I tried to memorize it, but I couldn't because I didn't want to miss out even one word from that, Corinne, because it's such an impressive title. It's an urban, it's getting the fundamentals right, role of rights accountability, and a holistic lifelong vision in ending maternal mortality and morbidity. I'm so glad I said that right. So we would like to have Corinne's slides up, and thank you, Corinne, and it's all yours now.
Thank you. Well, I want to begin by saying that it's a real honor to be in this room with the phenomenal energy and expertise that all of you bring, and also to be part of such a distinguished panel. I am really here to share the lessons learned from the challenges and successes of those working to end maternal morbidity and mortality, which provide insight into what was missing from the MDG approach, affirm some of the changes in strategy and entry points for the SDG approach, and provides examples of new tools and strategies and best practice which can inform the SDGs going forward, and not just for maternal mortality. I was advised prior to beginning that I should address the alphabet soup, which is endemic in such discussions. Just so we're all on the same page, the maternal mortality ratio, the number of deaths per 100,000 live births, i.e. not stillbirth, spontaneous abortion, or other modes of termination. This isn't really an empty exercise in that the terms and measurements themselves provide a little food for thought. The MMR, live births, does not include death and injury due to unsafe abortion and unwanted pregnancies, which is a major contributing factor to maternal mortality, particularly amongst adolescents. Maternal death, death occurring during pregnancy or within 42 days after delivery. They've had to create another category, late maternal death, for those which take place after those 42 days. Emergency obstetric care, EOC, which is a set of well-tested medical interventions that can be used at the end stage when one is in crisis. These interventions are effective, but prevention is best if possible. And skipped over, but very important, maternal mortality and morbidity is an acknowledgement that for every one maternal death, there are 20 women who suffer pregnancy-related injury or disease. So the numbers are much bigger than we imagine. Next slide. Oh, I'm so sorry. Thank you. In the early phases of the preparations for the SDGs to follow the MDGs, much attention was focused on the striking lack of progress on Goal 5, improving maternal health, with targets focusing on reducing the maternal mortality ratio and improving reproductive health with expanding access to contraception. And 45% may seem significant, but the story behind the numbers is more sobering. Next slide. The statistics don't reflect the fact that there were regional disparities, Africa being the most remarkable of them. It also highlighted the hidden cost of the morbidity factor, as mentioned in the previous slide. It pointed to the complicating factors of new epidemics, HIV and its role in maternal mortality. It emphasized once again the enormous disparity of deaths between developed and developing regions. And an ongoing examination of the data points highlights the difficulty of getting any real sense of the data without basic effective data on registration of deaths and births. These findings sparked alarm, protests, soul searching, and in 2013, a major effort to catch up before 2015, a special initiative on the part of the Secretary General, and another campaign to literally catch up on maternal mortality, and even the London Summit, in which the Gates Foundation and IPPF brought together donors to push major funding into access to contraceptives. Next slide. So what went wrong? Well, there are lots of reasons given, from lack of investment in maternal care, the overall health systems, resistance to sexual and reproductive health and education services, especially for youth, and failure to address the fundamental power dynamics which undermine a woman's ability to avail themselves of services before women are married and with 4 children, that is, start earlier. So, next slide. These criticisms all ring true, but there are 2 overarching elements missing. A call for a human rights-based justification and implementation approach, which both justifies the action on the basis of globally agreed human rights principles and makes sure that those actions solve the problems as they respect human rights, and an approach which goes beyond focusing on girls and women of reproductive age to looking at the compounding effects of gender-based discrimination against females from birth to death. And this includes everything from preferential treatment with respect to nutrition, education, and access to schooling, use of their labor, etc. Next. This slide is too small to meet Jean Stillman's standards. However, I just wanted to emphasize that the shortcomings of the MDGs relative to the SDGs are strikingly evident in looking at the goal on gender equality and empowerment of women. As you could see, for the MDGs, it focused on the target, eliminating disparity in primary and secondary education. In the SDGs, it focuses on all forms of discrimination everywhere. It looks at girls, it looks at all kinds of violence in the public and the private spheres. It looks at harmful practices, universal access to sexual and reproductive health, participation in economic and control over economic resources, political participation, and actual legislation. So in short, the SDG contributions are comprehensive, specific, concrete. They are more intersectoral than what's been experienced in the urban health universe, in that there are linkages and references across the goals. They look at the life cycle at all ages and girls, and they do reflect a human rights framework and approach. I might skip over Zimbabwe just for time. So skip this next slide and then the one following. Thank you. What are the rights that we're talking about? Well, in the past 20 years, the global women's movement has shifted its focus increasingly on strategies and tools which invoke the rights and accountability of state actors, for example. And this has helped transform the means or the how of social change. The rights we are talking about are drawn from universal human rights agreements, going back to Eleanor Roosevelt, but when they're applied to maternal mortality and morbidity, they take on a different meaning. For example, right to be free of cruel, inhumane, and degrading treatment, which anyone who has spent time in a maternity ward in a very poor area can attest is a real issue. The other, next slide, are drawn from the overall right to health, and the longstanding jurisprudence and debate on the right to health draw in some of the key human rights principles, including non-discrimination against women of a lower caste or girls, unmarried girls, and participation. So the human rights principles, which assure, next slide, that other rights are not violated in an effort to close the gaps and meet the targets, are these indivisible and intersectional human rights. In a rush to meet a target, it would be easy to ignore the rights and needs of the most marginalized populations, to fail to push for changes in norms on the basis of age or caste, and to fail to make any extra effort to be sure that those who are using the services are part of planning them. The most important point is accountability. This is the long missing tool in fostering really effective change. Those who have a legal obligation, the duty bearers, and those who are the rights holders entitled to services are the two key actors. Duty bearers are everyone from government to donors to non-state or private actors. And this is one of the most important set of tools because it really holds to account far beyond a shadow report on a United Nations agreement. What might accountability look like? Next slide. At the policy level, oversight by elected officials, or at the program level, accrediting agencies or community leadership. At the practice level, site visits to clinics, community checklists, and client representation on boards. There are also the National Human Rights Council's formal courts, and as referenced earlier by Ginger, the Universal Periodic Review process with the Human Rights Council in Geneva. So these run the gamut from popular approaches to juridical approaches, from formal national to international legal cases, and everything from formal legal cases to paralegals working with lawyers to help clients work the system. A very interesting hybrid approach, just as passing mention, is that of CARE, in which local women make site visits, interview clients, report back both to CARE and the Ministry of Health, and all of their results are sent to the Ombudsman, sort of the biggest lawyer in the land. So we can skip over the next slide. So in looking at what has taken place in the transformation between the MDGs and the SDGs, we hope that in going forward with this plan for the SDGs, we can look at their contributions as in the importance of the relevance of all sectors to addressing women and girls, the focus on youth and girls, using the established right mechanisms, and in implementation, making sure that we adhere to rights principles of accountability, participation, empowerment, et cetera, rather than running over those in an effort to meet a target. So thank you so much, and happy to answer any questions.
Thank you so much. Thank you, Corinne, for your passion and all the information you shared. And that's what I said when you've been all over, because I think you wove a very nice talk in which you touched on so many things and you brought in different perspectives. So in the interest of time, I'm not going to ask our panelists any questions. I'm going to turn to the audience. And as we've had in the previous panels, could you please raise your hand, identify yourself? Oh, yeah, lots of hands. And we'll take 3 questions at a time. And I'm going to be gender unbiased. So this is the first hand. I call across my male colleague here. Sir, could you please keep your question short, identify yourself, and which of the panelists you're directing it to? Thank you.
Thank you. I'm Mel Boynton from Southern California, UNA, and a wonderful panel. I am troubled by the complexity of the SDGs. It took us about 5 years to get to the 8 goals and 21 targets of the MDG, and I understand we now have 17 goals and 169 targets to convey in a time when our attention span is getting ever shorter. Any hope on that front, please?
Thank you so much. Next question. Yes, I'll go each side. Yes. Go ahead, please. Can you use your mic, please, or have somebody, could somebody give her a mic? Thank you so much. Yeah, thank you. Please go ahead.
Thank you. My name is Rory Munshine. I'm from the Southern New York UNA. My question is directed towards Ms. Guirguis. I'm sorry if I'm mispronouncing that. In your speech, you emphasized that vaccines work and that it's imperative to reach every child. However, as it stands, there are currently policies in place, like the WTO TRIPS agreement, that limit people's access to vaccines. So I wanted to know how you intend to eradicate diseases on a full level while balancing intellectual property rights and those concerns.
Thank you. I think, yes, one question right there, ma'am, and then I'll take the next round. Yes. Could you please introduce yourself, ma'am? Thank you.
I'm a holistic health educator and practitioner, and what I wanted to know was how has your organization been working with the World Health Day observance that happens every April 7th? And if it has, how effective has it been? And if not, why not?
Okay, thank you so much. So I think the first question, Corinne, SDGs, would you like to take a stab at that?
The toughest one of all. Well, actually, I agree with you that they are quite complex, but the slide in which I presented how the outcome of gender equality and empowerment was defined in these two approaches, MDG and SDG, I think illustrates that the MDGs were quite limited in, you can't make a complete statement about gender equality by looking at disparities in education. And you do need to look at power dynamics and some of the complexities within. That isn't to say that they couldn't be slightly more streamlined, and I think there's a recent piece just put out by Science that offers exactly that criticism, that it's very hard to measure. And what's also hard to measure is the synergies between these intersectoral interventions. But we don't want, as was previously discussed on the GDP, we don't want the limitations of econometrics and measurement to drive how and what we do with our interventions. So even if there are limitations in being able to track all of them, I think it sets all of those as priorities on the table. So there's probably, and actually Joe might be the better person to answer that, some streamlining that can be done, but I think that it's a huge leap forward in terms of recognizing really what is the essence of addressing gender equity and equality issues.
Thank you. Would you like to take a stab at that, Joe? Or
I mean, we understand that I think the Secretary General's preference is to keep the 17 and not argue over them, but there has been some conversation about clustering them conceptually, which probably would inform some of the metrics process. So I think but that's all hearsay. I mean, our colleague who's in one of the UN agencies may have a better sense.
Thank you so much. But I'm not going to ask you to answer the SDG because we need you to answer the polio question. Thank you.
Thanks, Rory. That's a great question. And you're right. As we saw in the 80s and 90s with ARVs as well, with HIV/AIDS, really important medicine and really important vaccines don't always reach the people that they need to reach. And I think collectively we need to make sure that intellectual property rights do not mean that the most vulnerable and the people who need medicine and vaccines do not get access to them. Just as an example, in the context of polio, there's a new vaccine that's been in use in the United States for many, many years. It's the inactivated polio vaccine, which is an injection. And for many, many years, this vaccine was not accessible to children across the world because it was too expensive. And just recently, there's been a lot of work with pharmaceutical companies based on partnership with WHO, with the Gates Foundation, public-private partnerships that have reduced the cost of this vaccine by almost 200%. And now this vaccine costs just $1. So it really, really reduces the number of doses, it increases the protection, and it's just an example of what can be done when we join forces for child health.
Thank you. And before I ask Dr. Boufford to answer the third question, I just wanted to take this opportunity to give a shout out to the United Nations Foundation for all the work they're doing with their Shot at Life campaign, because it's really great and it's reaching not only children in the US but outside. So I think it's really a great thing. And if you're not, again, they're not paying me to talk about this, they're not paying any of us here to talk about this, but please check out the Shot at Life campaign because it's really a great campaign you would love to be associated with. Absolutely. So now, over to you. Thank you.
Just very quickly on the World Health Day issue. I think these kind of things like World AIDS Day, World Health Day are very valuable as organizing focuses for the broader health community or individuals' particular interests in an issue. So I think the theme of the day is an opportunity to really bring global attention. So I think most organizations try to work with them and to use them locally with the idea of a sort of unifying regional activity. I would just put in a plug, since Minnie's plugging, but many of you here, of course, have probably not much interest in health specifically, but I would argue that any World Health Day, everybody should pay attention because it has to do with transportation and housing and education and economic development and all these other issues. So you're all part of being, it doesn't belong to health professionals, you're all part of promoting health in a community, so thanks.
Thank you. More questions? Yes, you first. Go ahead, please. Identify yourself. Yeah. Thank you. I think you're getting a mic.
Thank you. Thank you. Thank you, Dr. Murthy. My name is Sushant Bala. I am an epidemiology student from New York Medical College. This is a question in regards to the polio outbreak, Ms. Sherine. In regards to Syria, a region which is experiencing modern-day warfare, How are NGO and government groups coping with the polio outbreak? After all, in a country torn apart by rebel groups, contact tracing is very difficult. Due to individuals being dislocated to refugee camps in neighboring countries such as Iraq. Therefore, I would expect the number of reported cases to be heavily underreported. Thank you.
Thank you so much. 2 more questions. Yeah. I see one hand up there. Yeah. Yes, go ahead, please.
Hello, can you hear me? Okay, perfect. Hi, first of all, I would like to say thank you for all of the wonderful information that you shared with us. My name is Gabriela Taveras, and I am the president of the United Nations Association at Seton Hall University and a youth representative for the United Nations Association of the Dominican Republic. I'm from the Dominican Republic, a country where the practice of gender equality is a rather young idea, and this is an area where we're still learning and growing. Hence, I would like to know, and this is a question directed to all of the panelists, what are some of the examples of best practices that you have examined at a local level? And further, which of these practices have you found best engage college women and men in campuses throughout the United States? Thank you.
Thank you. One last question. Yes, I see. Yes, sir. Go ahead.
Hi. Thank you again for the wonderful panel. So one of the shortcomings of the Millennium Development Goals was that I'm sorry, my name is Jose. I'm former UNA Brooklyn, board director of UNA Brooklyn. And my question is that one of the shortcomings of the Millennium Development Goals in terms of attaining them is that it was a lot easier for the developing countries to achieve them because they got access to technology that enabled them to achieve those goals. And to attain the Sustainable Development Goals is going to require new innovations in technology that we don't even have yet, maybe not even imagined yet. So my question is what are we doing to engage the engineering and the STEM community to really be part of this solution? Because if we don't have them part of the equation, I see health, I see public policy, I see all these things, and I've been to this conference for a few years. I have never seen an engineer come and talk.
Thanks a lot. It's not that I want to cut you off, but because we are under a time crunch here, so that's why I would like to request each of our panelists to kind of, it's called the lightning answer. Like you have speed dating, you have lightning answers here. So I think Sherine, we had Sushant asking you about polio. So your time starts now. You have 30 seconds.
Okay. Oh, this is a race. So Sushant, you're absolutely right. Places of conflict do give us extra cause for concern. We need to make sure that we are actually getting all of the cases that are existing. And some of you may have seen a lot of debate around Syria from Annie Sparrows. But one of the things we do track is surveillance. So there's a certain number of cases that should pop up of paralysis per 100,000 population. If we get less than that number, we know our surveillance is probably not picking up the cases. And thankfully, in places like Iraq and Syria, we know for the most part our surveillance is working. There are some pockets that we don't have access to, but usually from our experience, those cases come up within a year. And so even if the surveillance is broken, it's pretty impossible for a polio case to go completely undetected. So come back to me in a year and I'll let you know.
Thank you. Could I ask you, Joe, to just answer the question about STEM? And then Corinne, I haven't forgotten about you or the second question we had.
Specifically to the issue of engineers, it's very interesting, and for the next generation of engineers are not very active. They're not big groupies. So when you look at the global associations or the national associations, engineers generally are not as visible, and therefore they're not as much a part of these conversations. So I encourage you to change that in your own situation. But the couple of things that are important, that are signs of this happening. The International Society for Urban Health that I mentioned, the next meeting is going to be in Dhaka, Bangladesh. The participants already, it's an abstract-driven meeting. Engineers, urban planners, transportation experts, epidemiologists, climate change specialists, geographers, behavioral and social scientists. So they're already coming together on the urban issue, and I just encourage you to think about these are all determinants of health, so don't be put off by health. Health is not just medical care. It's a whole set of things that make people healthy. And the International Congress of Scientific Unions, which is the global network of physicists, mathematicians, architects, the sort of hard sciences, they have adopted a 10-year research initiative in urban health.
Thank you so much. Corinne?
I just want to add a little bit to what Joe just said, and that is actually I was involved in writing a chapter for a book called Sexual and Reproductive Health in Africa, which was targeted at students who are not in the health field and not in the sexuality field, with a recognition that things like sanitation, public works, education, transportation are all part of the solution. So that is a very important one. I guess with respect to the question from the DR, my answer would be any program that is a best practice needs to start early. It needs to be consistent and intensive over time. It needs to involve boys as well as girls. It needs to address agency and structure, that is, empowering the girls, empowering the boys, but also recognizing that when girls go out there, they face a very different scenario than boys in terms of applying what they've learned in these programs. The other would be that sexuality is a very good entry point for that holistic approach. There is a global curriculum called It's All One Curriculum, produced by the Population Council, inspired, in fact, by a program for girls in Nigeria, which includes all of the information, but also skills in advocacy, skills in negotiation. That's part of what's needed. It's not just knowing your body. And then finally, on campuses, I think there are a great many movements dealing with gender that would provide a great entry point to speak to that. Now, what is in the DR, I can't attest to, but I know that just within the U.S., Let Girls Lead is at the high school level. The Roosevelt Institute has a network. Half the Sky has a network. And many programs actually have overseas experiences, which could be informed by a gender perspective.
Thank you so much, Corinne. And keeping with lightning round of summing up, I would like to say, Margaret Mead, it takes a small band of dedicated people to change the world. I see that in this room. I see that on the podium here. Otherwise, we wouldn't be here. So thank you all for being a great audience. And thank you, panelists. It was a pleasure. Thank you, Chris and Ginger. And we are ready to move on. Thank you.